Thank you again to our panelists. If anyone has a question or comment for this group, please come to one of the microphones. There's a couple of housekeeping statements first. Please state your name and affiliation when you come to the microphone, and if you have any significant conflicts of interest, please do state those. And also, please keep your question or comment to less than 1 minute to give enough time to the audience to pose their questions.
Thanks. I think the mic, can you hear me? Stu Berger from Chicago Lurie Children's Hospital. One of the recurrent themes that we've heard here and many other forums is the lack of public awareness, certainly beyond the group that's here. So the question I have, and I think maybe I can direct it at Robert and at Joanne, how do we get to the media, and how do we get, for example, to what Joanne and her group have done with breast cancer? The NFL every certain Sunday wears pink, right? At certain weeks. Maybe we can alternate and wear red for a public service announcement for sudden cardiac arrest and the importance of lay rescue or CPR. The number one athletic event that affects young athletes is basketball. Maybe we could find an NBA spokesman, and every week or every so often on TV, and I hate to focus on sporting events, but a lot of people watch sporting events. The NBA could advertise or talk about the public awareness and importance of lay rescue or CPR. How do we get that done? I think it'd make a difference, but the question is how.
I'll do campaigns first.
Well, a couple things I would say. First of all, you know, a lot of the money that got spent on awareness of breast cancer, I don't have the power, but I'd give it to you right now, because I think we've gotten the awareness at a higher, so much higher level than we have this particular. You know, I think it's become a thing that is a comfortable place for people to be. You know, if you go back 35 years or 40, Betty Ford barely would talk. I mean, she was the first person to talk about breast cancer. Now I think when corporate America is trying to say we're good guys, nothing makes them happier than to put something pink on. But what is any of that really doing? I think most people by October just say enough already. We've had enough of this pink stuff. So I'd give it to you. I don't have that power. But it's because it's political, I think. By political, I don't mean Democrat, Republican. I mean the companies, the corporate world have become convinced that this is good for their image, back to your branding thing. And I think it builds on itself. I was also involved in the issue around domestic violence, you know, and they got Joe Torre at the Yankees very involved in this issue because he had a history of it. So I think your idea is a good one. One of my questions, because I don't know enough, who is the they that's going to the MBA or the whatever? I mean, because that seems to me one of the challenges is you all care a lot about this, but is there an entity that is similar to the Breast Cancer Coalition that has taken this up? You've got a great commercial of a number of people, but is that happening? Is there a grassroots effort among people is there an organization? I don't even know.
A lot of the campaigns do take a lot of money. Some of our Heart Association colleagues may be able to tell us how much the Red Dress campaign costs, for instance. But public relations firms have been hired to do this. This isn't just a bunch of people in a room. They go to professionals, they hire professionals, and they come up with a campaign that, as you said, it's a good distinction, does become political. It becomes motivating for change and action. But it costs a lot of money. You mentioned the media. The media is free, but the media likes stories. And for my money, there's no better story than the survivor and the victim that they saved together. That is, it brings tears to my eyes every time I see it. So, you know, whenever we can get any kind of story that is newsworthy, and that's not what we always think is newsworthy. Newsworthy is either really heroic, really rare, extremely rare, or it can be controversial. So again, another way to make news is to hold your folks accountable if you're in a city that's underperforming.
But I didn't hear an answer to the question. Is there an organization that is, but I mean,
If I could answer that, I think that there's a lot of organizations working in silos.
silos.
Yeah.
Well, that's then a good model. I mean, as I said before, no, but I meant is
Yes.
if you
It's not.
can have a specific, but the thing about the Breast Cancer Coalition, primarily it was people who were focused on breast cancer. As opposed to, again, I don't know, but looking at those lists, I mean, people that are involved with all different kinds of public health issues around heart and heart disease and whatever, but this thing that's sort of going to shine a light on this issue, cardiac arrest, and trying to create, I mean, I don't know that that's the right thing because I'm new to the problem, but that's part of the whole thing, is if you want to get it into being more of a public discussion, there's got to be a strategy to what, and an agreement upon what the strategy is, and as I was saying earlier, a focus on what it is, and then you go forward and you do it together. But it's got to be driven by, now, when the Breast Cancer Coalition started, I mean, there were, first of all, a lot of other breast cancer coalitions. Somebody mentioned Komen earlier. I mean, Komen existed, and Komen was always like a, $100, $200 million organization. It was a big organization. But when the Breast Cancer Coalition started, I mean, it was very small, and it remains relatively, comparatively, a small budget organization that has made dramatic change because of some of the structures and goals that it put in place.
Tom Ofterheide, I'm an emergency physician at the Medical College of Wisconsin. No conflicts. My question is for Joanne. We're going to be talking about possible formation of a cardiac arrest collaborative tomorrow. And you mentioned that 25 years ago there were groups all over the country. What do you think you accomplished by forming a coalition that you couldn't accomplish by just letting these groups continue their work all over the country?
Well, the difference was the groups decided that they were involved with support groups or education or whatever. But what they decided is that they felt to end breast cancer, it's fine, to continue to have support groups and education. To end breast cancer, we needed to have an advocacy, strategic, system change operation. So that's what they couldn't produce by themselves, is they could, and we still haven't produced it, but we're making, we hope, progress toward producing it. But that's what coming together, so that the training I talked about and the involvement and all that gets produced when you have a national effort that people then can participate in. What we're very involved with Capitol Hill, although frankly it's a much more frustrating thing for all the reasons you were already talking about. It's not just trying to get more money for research; it's trying to get them to. Anyway, but we have a lot of field people, and they're very involved in Capitol Hill and trying to make things happen on Capitol Hill too. And that's another thing. You have to have a legislative strategy. Then you have to have people all across the country who can implement that strategy.
So reading a bit between the lines, then, you were able to generate professional help, marketing, message crystallization, lobbying groups, et cetera, through this organization.
Yeah.
And last quick question, how do you sustain this group? What is your funding source, and how have you kept going for 25 years?
Well, funding sources is tough, as I said. The Race for the Cure, Komen, everybody's aware of, raises hundreds, or used to at least hundreds of millions of dollars, because people went out one day and they raced and they committed some money. When you're doing things that are trying to create systems change, it's much harder to get funding. So it comes from cultivating, it's I would say 80% of the National Breast Cancer Coalition's funding comes from individual donors who believe in this advocacy change, which is not always an elevator speech. I think you've got an elevator speech. You know, I don't think I mean, I know this is just how to prevent somebody from dying at the moment, and what you all additionally, of course, want to do is how we prevent people from having cardiac arrest. The same thing with breast cancer. We want to have people stop dying from it, but while we're doing that, let's figure out also how to stop it from happening. But I think you, in some ways, have a simpler elevator speech, which I mean, you can say it in a couple of sentences, what you want people to do. This whole public awareness campaign. I'm just like that when you were talking about it. I mean, until I came here today, I'm not convinced I'm going to go learn how to do it. But I was always a little jittery about this CPR stuff and whatever. No, I was, I'll be honest. So, I mean, I think that whole message that you have, that there is something that people can really do. I mean, that's an empowering thing for people to know. You have a responsibility, including me, to know how to do this. You can save someone's life. You have a responsibility. And you know, now in this world that is so, oh God, tough, people want to have some little thing. You know, maybe they get this hero's badge, you know, I know, that people get if they go get this training, you know, something that says, I'm stepping up for my community. It could make people, when we all feel almost so helpless to do anything that can make a difference.
Thank you.
Yeah, Bob Meyerberg, Miami. So, Raina, I'm sure you're aware of this, but there's a paper about to come out in Jack about not the issue of access to AEDs, but accessibility, talking about nights and weekends. And it's a very nice study that looks at the issue that the nearest AED may not be an available AED at the time that it's needed. And what they've done is model their system so that the nearest available AED will be. This is an important observation, important statement. It'll be coming out soon. As far as athletics are concerned, the NCAA has sort of finished its mission for concussion research. They've implemented a wonderful program. It's working well. And now they've shifted over to cardiovascular. Great. And they just published a paper that covers the issue of what they and we should be doing about cardiac disease in athletes and cardiac arrest, mainly obviously focused on college athletes. And a big part of their message has to do with the sort of thing we're talking about, including the availability of AEDs. Their mission does not end with their paper, because they're now setting up, hopefully, based on the input we've given them, a regional series of centers for cardiovascular modeling, research, evaluation, and compliance with AED recommendations across the country for colleges, which is mainly relevant to the Division II and Division III colleges, because they are far more numerous and have less access than the major schools.
I think that's a really, really important point, and particularly that it's not just about knowing where AEDs are. They have to be accessible, they have to be available, they have to be visible. I think that location should be memorable. They have to be working. You have to be willing to open the box. You have to be willing to actually use it. So there are a lot of different steps that have to happen. And I think that some of the things that we can do in terms of using innovative or different approaches relate to a lot of the conversation we've had around media and around marketing and around making it seem really seamless, making people want to be proud of the fact that they have the device there, that the device is working, they want it to be visible. Everyone doesn't need to have a Superman around their AED. I can imagine locations where that wouldn't work, but really sort of trying to focus on it and thinking of different ways of engaging the public to want to perform CPR, to want to access AEDs is really important.
Dr. Merchant, as long as you're on a roll, a number of years ago, Knox Todd and Cheryl Heron did a really cute study with a cardboard mannequin and an old VCR tape using a curriculum that Alan Braslow, Alan, you in the audience, wave, developed. And it worked with African-American church members. Then some years after that, I thought that was a cool study till this clinical scholar did this really cool study with a cell phone, images, full volume, and got a bunch of vets to do CPR. What is the state of the science today on cell phone CPR, and why do we not all have an app in our pocket, whether or not, Ms. Howes, we've ever learned CPR, just to show us how to do hands only, just pump till help arrives? What's the current state of the art on cell phone CPR?
No, it's a great question. How many people have an app right now on their phone that will walk them through how to do CPR? Not everyone. Or to find AEDs. I mean, I think that is somewhat of the state of where we are with cell phone CPR. I mean, I think there are a lot of, so everyone should download an app. There are lots of them out there. But I think that there's a lot of opportunity. I think most of us have a cell phone with us, and in terms of being able to walk people through how to do CPR, in terms of a great refresher, in terms of many of them have metronomes. I mean, I think that there have been several studies showing improvement in terms of confidence in doing CPR and ability to do CPR with this sort of just-in-time training. And so I think there's huge opportunity. It's actually how do we get people to adopt and actually use these things and actually regularly access them. I think one of the opportunities is that even though for those of us that have the app on our phone, when did people last use it? And so not making CPR as something separate from our everyday lives, but incorporating it into the apps and the things that we do on a day-to-day basis is more likely to increase adoption and utilization. And so I think that our challenge is really in making this seem seamless and associating some, you mentioned a badge, but people wanting to be proud that they, know CPR, that they have the app on the phone, and thinking of ways to integrate it into our day-to-day activities.
Okay, so before we continue, I have less than 3 minutes left, so I'm going to ask everyone to limit their comments to 30 seconds.
Okay.
And
All right.
just the people that are up on the microphone already.
I'll be brief. Ben Abella, University of Pennsylvania. Really a comment more than a question, and an actionable comment suggestion for the organizers. When we see these videos like we saw before, they're wonderful. We're really talking about trying to influence behavior change, and I don't know if we know if those videos do that. And my suggestion is that we actually have experts in behavior change at these things. For example, people in marketing or advertising whose whole lives are about putting messages before the public to change behavior, change purchasing behavior. I think they know a lot more than we do, and they should be part of the conversation. The other group I'd suggest when we think about behavior change, there's a growing field called behavioral economics, where people get paid or in some other way incentivized to do behaviors. I don't know if they've had much interaction with the resuscitation community. I haven't seen that. But I think, for example, workplace incentives to learn CPR or other behavioral economics techniques should be applied, and those sorts of folks should be invited to the conversation when we have future meetings.
A great suggestion.
Just having dabbled in some of this thing about CPR training or getting people over the years, I'd have captured audiences like in school systems important, and there when you have the peer group, like a 17-year-old training the 14-year-old, they think it's cooler, and there's they put it on their CVs and all that. Secondly, for sustainability purposes, putting it in places like the workplace, if you can get in front of city council or get in front of the boardroom, we're going to give you a free CPR class, and they go, oh, it's easy, and they actually report back that they've saved someone's life within 3 or 4 months, which has happened to me several times. That's been very useful. And then what you say to them sustainability-wise, you can train all your people, but as new people come in every year, 10% of the workforce, 15% can be, that's part of their orientation. In 15 minutes, you get one of those CPR kits, and then it's sustainable and cheap, and you get everybody trained. But you got to start it as part of the job, even, and whether it's a large city employee or Texas Instruments, where I come from, or whatever. Those are a couple suggestions for getting to the public and making it happen, okay, and sustaining it.
Thank you. Dr. Chandra Strovos.
Johns Hopkins, Chandra Strovos. The cost of care delivery for post-resuscitation patients has skyrocketed with no change in survival. Maybe we need to ponder on the message we are conveying in the media, because everybody thinks everybody's going to wake up. So a tempered message and how should that be delivered?
Mary Newman, Sudden Cardiac Arrest Foundation. I wanted to mention that we recently conducted a public awareness survey working with Strataverve Market Research, a consumer study of 1,000 Americans, and found out that sudden cardiac arrest is not on consumers' radar. Out of 1,000 people, not a single person mentioned sudden cardiac arrest as a key health care concern for them or a member of their family. We also found in doing some one-on-one interviews with people in the streets that that even people that had CPR training didn't know what it was for, didn't realize the person would be clinically dead, et cetera. So one thing we found is that if people were given a very clear definition of sudden cardiac arrest, they were much more likely to be interested in learning CPR and learning how to use AEDs.
Thank you.
Hi, Peter Antevi from South Florida, pediatric emergency medicine and an EMS medical director. I tend to disagree with using applications for CPR. I think that the messaging is all wrong. If you listen to the 911 tapes, and Ken and I do that quite often, even our call takers have a very, just like Joan felt a little jittery a minute ago, there's some psychological barrier that doesn't let people do that. And I think we've created it, the medical establishment. We've told people that to start CPR, we should call 911 first. Where did that come from? And why is that the case today? How come parents, when their child is dying in front of them, won't push in their child's chest? We've created that, I think. So if you look at the World Congress on Drowning, what they've done, they're saying is do something. I think we have to change our messaging to, it doesn't matter if you use your heel, your hand, 30 to 2, 4 centimeters, 5, 6, it doesn't make a difference, really. I think we really have to change our messaging as a medical community, because if we go ask the lay public, why don't you do that, I think ultimately it'll come down to, it sounds a little complicated, and really it's not that complicated. Thanks.
What we heard last night at dinner.
I think it's
Okay, well, that will close this panel. I'd like to thank our panelists for their time and their expertise. We now ask everyone to go to their assigned breakout rooms for session 2. Snacks and coffee and tea are available in the Great Hall. For those of you that will be in a breakout session in this room, please remember that you need to finish coffee and snacks outside before returning.